All right, good morning. We're going to go ahead and get started. I've got a quick announcement. Today is the second to last grand rounds before we take a break for summer, which means it's evaluation time. And so we'll be sending out a link for an evaluation after today's meeting. It only takes about 5 minutes, so please fill it out. It's very useful as we're planning future grand rounds meetings. And there are also some paper copies out by the coffee if you would prefer a paper copy. So thank you for your help with that, and we'll go ahead here.
Good morning, everybody. Can you hear me okay? So it's a pleasure to be here to discuss this topic that is often on a lot of our minds as we're dealing with Tavor, which has been a revolutionary technology in our field. And from an electrophysiology side, what I'd like to do is cover some of the electrical aspects that we look at when we consider pacemaker implantation after Tavor. And I just want to say a word of thanks to Dr. Goessl and the valve team, along with our entire electrophysiology team. It's been really fantastic to work together to kind of develop a protocolized, systematic way to deal with these very difficult clinical situations that we experience. And we have a wonderful team, and going forward, I'd like to say that I have an answer for all of the different clinical conundrums that we face when we deal with certain issues with the electrical disturbances after Tavor. But I don't have a magic bullet. But with this collaboration, we hope that over time we'll develop a very novel way to deal with these patients that probably will establish guidelines across the country. So having said that, I have no personal disclosures. I do participate in industry-sponsored trials with the Minneapolis Heart Institute Foundation. So what is the scope of the problem when it comes to conduction issues after Tavor? We'll touch upon that during the course of this discussion. And more specifically, and probably the more interesting question, is what we do with the patients who develop a new left bundle branch block after a Tavor procedure. And we'll talk a little bit about the anatomy and pathophysiology of why that occurs. And you can think of these aspects from an electrical standpoint and from a mechanical standpoint. So that's why Dr. Goessl is here today. So basically we're collaborating to provide both sides of this issue, because there are factors on both sides that tend to predict how a patient is going to respond after Tavor with respect to their conduction physiology. And together, we hope to work towards developing a uniform and practical approach to dealing with new conduction disturbances after Tavor, and ultimately discuss shared decision-making as an approach to making patient decisions, both decision-making discussions with the electrophysiology and the valve and the cardiology teams that are taking care of these patients, and also with the patients themselves as to what the best options are in terms of treatment and optimal patient care after their procedure. So I do want to illustrate a couple of aspects that we see and start with two cases. So this is a gentleman, 89 years old, with a trileaflet aortic valve and severe aortic stenosis. He was deemed moderate risk for open surgical aortic valve replacement and then enrolled in the Partner Sapien 3 registry. His valve hemodynamics are there with peak velocity of 4.7 meters per second, mean gradient was 52. He had a history of paroxysmal AFib. He was on amiodarone pre-procedure and continued through the peri-procedural period. He has a history of LVH and an ejection fraction of 45%. He also had moderate restrictive pulmonary disease, another factor that kind of pushed him towards going for Tavor, recommendation of Tavor as opposed to open surgical replacement. So he underwent successful deployment of a Sapien 3 pericardial bioprosthesis. The procedure included a balloon valvuloplasty, and he was described as having an incomplete or transient left bundle branch block noted after the Tavor, and a temporary pacemaker was inserted because of that factor at the time of the procedure, and he went to the floor with that temporary pacemaker in place. So on postoperative day 2, he was progressing well clinically, described as out walking with his nurse. He had good hemodynamics. He was on a little bit of oxygen, presumably related to partly the procedure and his underlying lung disease. And otherwise clinically at baseline. Otherwise, from a organ standpoint, doing very well. He had an excellent result from the Tavor. He remained on his home dose of atenolol and amiodarone. And his EKG, I don't have the exact EKG, but it was described as having a QRS duration of 116 milliseconds. His baseline had been 108 milliseconds, and his temporary pacemaker was removed. So this is post-op day 2, and his temporary pacemaker is removed. He's doing great. And a few hours after his temporary pacemaker is removed, he's on the floor, and this is what happens. So you can see here, it's actually quite interesting. His QRS appears to be a little wide. He's in sinus rhythm. And then you have this period of time where the QRS widens. Potentially a new left bundle branch block. Sometimes we can also see a PVT come in and fuse with the native QRS. We see this in electrophysiology, sometimes where a PVT comes in and conceals into his Purkinje system, rendering it refractory. And, but essentially what happens, either way, either if this is a widening of the QRS representing a new left bundle or a PVC coming in, essentially afterwards we have a complete heart block. And the sinus rate stays about the same. Another possibility could have been a vasovagal episode or an asystolic arrest for other reasons. But essentially, you have a sudden heart block and an asystolic cardiac arrest. There was no change in sinus rate. He reported later that he was laying in bed at the time this happened. And so he received approximately 1 to 2 minutes of chest compression and subsequent return of spontaneous circulation. The progress note at that point mentioned that he continued to be externally paced. He was taken emergently to the CV lab, and an EP consult was placed for permanent pacemaker implantation. He later underwent a dual-chamber pacemaker implant during this hospitalization before discharge. And I just want to bring out a couple of points after as far as the follow-up, because this will illustrate aspects that we dealt with in terms of our retrospective analysis of these patients. So at the 1-month pacemaker check, he continued to have complete heart block, and he was in atrial flutter and atrial fibrillation, and he was pacing per the device 99.6% of the time in the ventricle. At the 6-month pacemaker check, he was in atrial flutter with intact conduction at 60 to 95 beats per minute with 25% ventricular pacing. So in isolation, if you hadn't known about his initial history of having a sudden complete heart block, asystole, and you had only information about the 6-month pacemaker check, you might say, well, he has intact conduction, he's not pacemaker dependent, but most people would agree that this person, if we were to remove the pacemaker, we would potentially risk having a similar clinical scenario occur, of potentially life-threatening. So the patient is at this, one could call this partially pacemaker dependent or completely pacemaker dependent, depending on how you look at it. But it goes to show you how the pacemaker check provides a piece of information about how the patient is utilizing that pacemaker, but it has to be placed in context with the entire clinical picture, because we would all agree that this patient needs the pacemaker. So this is an interesting point, and I'll come back to some of these principles later. Go on to case number 2. So this is a 68-year-old male with it's kind of an atypical Tavor case, but he had an aortic dissection, type A aortic dissection, that was surgically repaired with the interposition graft in an outside hospital. He presented to ABED. He was noted to have severe aortic insufficiency. The non-coronary cuts of the aortic valve did not coapt with the other 2 leaflets. He was deemed to be very high surgical risk. He underwent TAVR with a 31mm Medtronic core valve by percutaneous transfemoral approach. He also had a temporary pacemaker in place, active fixation lead, post-procedure, and this was what was identified on his monitoring, cardiac telemetry. So you'll see that he's in sinus rhythm with a left bundle branch block, and then suddenly he again develops complete heart block. And then you have ventricular pacing spikes followed by ventricular capture and paced complexes. And T waves are marching throughout the strip you see here at the same rate. So basically sinus rhythm, complete heart block, ventricular pacing. As is, of course, a temporary pacemaker, so it's not synchronous with the sinus rate. Now, this could go on for 30 seconds. It could go on for 10 minutes. If you were to interrogate this pacemaker at 6 weeks, you might find maybe 5% ventricular pacing, or maybe 1% ventricular pacing. However, one would argue that during those periods of ventricular pacing, he may have some heart block and be quite symptomatic with that. So what are the symptoms? symptoms of advanced conduction disease, either left bundle branch block or high-grade AV block. And when I refer to high-grade AV block, I'm referring to anytime you have more P waves than TRS complexes. So anything more than Mobitz 1 or Mobitz 2 to where you have 2-to-1 AV block or even more serious. So, oftentimes we have all seen patients come into the emergency room complete heart block and they're dizzy, they're lightheaded, they've been fatigued. Sometimes they're able to tolerate this for several days at a time, or it's unclear the exact duration that they've been in complete heart block. Sometimes it can lead to confusion, delirium. Sometimes we notice concomitantly, either related or unrelated, that there could be atrial or ventricular arrhythmias. There are Brady-dependent ventricular arrhythmias. Brady-dependent torsades is a possibility, and that is a potential cause of sudden cardiac death in individuals with bradycardia. And then syncope, asystole, sudden death. These can be as a result of either bradycardia or ventricular arrhythmias related to their bradycardia. And of course, congestive heart failure oftentimes can be associated with left bundle branch block, associated synchrony, and reduction in ejection fraction. And oftentimes people may come in when they're in complete heart block, and you may notice that they're actually hemodynamically hypertensive and say, oh, they're stable, that's okay. When in essence, actually, they may not be. They may be in a low output state. They're compensating essentially for that low output bradycardic state and shunting blood to the vital organs. And you may see indeed signs of end organ hypoperfusion and injury in those cases. So in these two cases, pretty illustrative of potentially what could happen with conduction disease that occurs after TAVR and how it could be sudden and potentially very serious, if not catastrophic. So why is this a potential possibility? This is a schematic. I'll get to an anatomic representation in a second here. I just wanted to give you an idea of how close the aortic valve lies in proximity to the critical aspects of the AV conduction system. The AV node and the His bundle laying very close in proximity. And then we have the membranous septum of the ventricle where the His bundle penetrates through and then divides into the left bundle branch block and the right bundle branch block. And you can see how deploying a valve, particularly Tavor type valve, with self-expandable or balloon expandable type, can encroach upon the conduction system. And there are various factors that could determine in a given individual how much of the conduction system is impinged by that valve deployment. And then, of course, the conduction system progresses down and extends down to the His-Purkinje system, moderator band His-Purkinje system, and Purkinje fibers. This is anatomically what we deal with very commonly in the EP lab, this triangle of Cook. And here you see what's called this fibrous tendon called the tendon of Tadaro. The base of this aspect, this is looking into the right atrium. Just to orient you, this is the fossa vallis, this is the left atrium over here. This is the interatrial septum and the interventricular septum here. And just opposing this on the other side, you see the leaflets of the aortic valve. And in this triangle of Cook are very critical structures. The coronary sinus is at the base. The apex of this triangle is the His bundle. This is the septal side, the septal leaflet of the tricuspid valve is here. And then within this area, you also have the AV node, the compact AV node itself, which can have extension to the left side and over to down toward what we call the slow pathway region. So the His bundle penetrates through this membranous septum of the ventricle and then comes out on the other side. And if you were to look at it anatomically, you can appreciate the left bundle. It's a cable of conduction fibers that runs there. And the left bundle is itself very complex as well. Just to show you a couple images of the left bundle. This was an autopsy series looking at 30 different hearts, and they tried to characterize the progression of the left bundle in the left ventricle and how individually there were at least 15 different types of left bundle anatomical relationships. The left bundle is claimed to always divide into left anterior and posterior fascicle. Some people actually do have what's called a septal fascicle. And depending on that anatomic location, you can imagine how an aortic valve deployed in that region may impact the left bundle in that location. The other interesting thing about this is that there are variations not only in the left bundle anatomy, but also in the His bundle, the AV bundle itself. About 50% of individuals exhibit a right-sided AV bundle, 30% have a left-sided, and 20% have a bundle that courses just under the membranous septum below the endocardium. And these individuals may be more prone to having a new left bundle branch block or heart block associated with a aortic valve replacement, given the proximity of the anatomic location. So a native QRS looks nice and narrow as the electrical conduction penetrates through the His bundle across the bundle branches, and kind of in parallel, the left bundle activates a little bit before the right bundle, but as both bundles are activated in parallel, you have both sides of the ventricle, both the left and the right ventricle being activated simultaneously and synchronously to give you this narrow QRS. A right bundle branch block, particularly one that's pre-existing in someone with conduction disease, and I just want to make a caveat that right bundle branch block doesn't necessarily mean that there's complete electrical block in that fiber. It may just be delayed. But you can imagine if someone already has pre-existing right bundle disease or a EKG that looks like this prior to their TAVR, and then you deploy the aortic valve on the opposite side, impinging on the AV bundle or the left bundle, how that person could potentially be at higher risk for developing complete heart block or progressing to that after such a procedure. These are a couple of the older generation valves, the Edwards Sapien valve, the Medtronic core valve, but just to basically schematic representations just to give you an idea of how they sit along that aortic root, and that there is architecture of the valve below the aortic root in that critical area that we talked about along the interventricular septum and the membranous septum of the left ventricle. So what is the pathophysiology of contributing to either new left bundle branch block or conduction disturbances after TAVR? Through autopsy studies, a direct mechanical insult has been described, either related to edema, hematoma, ischemia in that area, and this has to do with the radial forces of the valve directed at that LV outflow tract. So there are valvular aspects, there's implantation aspects having to do with the valve diameter, and also there's host aspects, calcification of that tissue. And there's also, like we discussed, anatomical variation of the AV node, as well as the His bundle and the left bundle. And then there's aortic stenosis-related conduction disease, potentially calcium deposition on the conduction system, left ventricular dysfunction. All of this could predispose to having conduction anomalies. So here's a summary of the incidence of new onset left bundle branch block after transcatheter aortic valve historically. And this is looking at the older generation valves, the Sapien Medtronic core valve, and you'll see that the Sapien valve, which is the balloon expandable valve, tends to have a little bit less association with new left bundle branch block, about 10% in some series, up to 30%. The core valve having a little bit more higher trend to having higher incidence of left bundle branch block described, sometimes higher than 50% in certain studies, certain series, in terms of after implantation of the device, and both valves together anywhere between 10% and 30 to 40%. Looking at some of the newer valves, and Mario will get into a little bit more detail on this, it is thought that these may be potentially safer when it comes to conduction anomalies, but there have been, and we don't have full data on them, but there are descriptions of significant conduction anomalies related to these valves as well. And this one's looking at the Sapien 3, anywhere from 10 to 20, a little bit more than 20% in terms of incidence of new left bundle branch block, St. Jude Portico, also, this one, and the Lotus valve from Boston Scientific. So most conduction disturbances related to this implantation and valve and host factors occur in that acute period after the TAVR deployment. A small percentage of the patients can develop subacute left bundle branch block. And in the Sapien 3, looking at different series, we've found 12 to 22% of patients have new left bundle have been reported after implantation. And if you look at follow-up, and we'll get to what this really means, pacemaker rates vary from 5 to 14% in follow-up among these patients. And the majority of patients have AV block and thick sinus syndrome as primary indications for this implantation. But as you know, there is no consensus of when and in whom to implant pacemakers. So some of these patients do have symptoms prior to implantation of the pacemaker. Some of them have prophylactic implantation, depending on the center and the operator and the care team taking care of the patient. So there is a lot of variability. We'll talk about that in a moment as well. Now, left bundle branch block what does it mean long-term for a patient who develops it after TAVR? That is a very a controversial subject because there's been an inconsistent association between new-onset left bundle branch block and all-cause mortality. There's some meta-analysis that failed to show significant association between the occurrence of TAVR-induced left bundle branch block and 1-year all-cause mortality. Left bundle branch block in the ARENA series was associated with greater 1 risk of cardiac mortality, particularly when the QRS duration was wide at greater than 160 milliseconds. And that was proposed to be potentially due to either progression to high-grade AV block, complete heart block, ventricular arrhythmias, or ventricular dyssynchrony associated with that wide QRS that could lead to either decrement of their ejection fraction or no improvement in their ejection fraction after the procedure, or congestive heart failure and related sequelae. So this is just a table summarizing some of those studies. Some did not show a significant increase in mortality at follow-up, and some did. And why would that be the case? Well, remember again, there's a variable approach to implantation of a pacemaker after a left bundle branch block. So whether it's protective or not is not necessarily clear. Also, you may have patients presenting with bradycardia or complete heart block symptomatically, but not necessarily result in sudden death. So there are variations, as we discussed, as to how one might present with their left bundle branch block, or if it progresses to complete advanced AV block. In this particular study that I alluded to earlier, so they did look at patients who had developed new left bundle branch block after TAVR and then had persistence of that left bundle branch block compared to no persistence. And there was a slightly higher trend toward mortality in the patients with persistent left bundle branch block at 2 years, suggesting that there may be an early sign of increased mortality, but also that later on there could be progression to heart failure and sudden death related to the left bundle branch block. But what was particularly interesting, it was in patients who had a particularly wide QRS duration. These patients at QRS of 160 milliseconds or more of their left bundle clearly had a higher mortality associated with their long-term outcomes. So what are the risk factors for new onset left bundle branch block? We've kind of covered this indirectly. Either they have pre-existing conduction disturbances. Also, there are clinical factors maybe associated with it, such as female gender, prior CABG, diabetes, the amount of calcification on the aortic valve, the use of self-expanding valves, and then other factors that have to do with the implantation. Mario will go into a little bit more detail about that strategy, but the prosthesis implantation depth within the left ventricular outflow tract, and whether or not other associated procedural interventions are taken, such as balloon pre-dilatation or implantation of a large prosthesis in a small left ventricular outflow tract. What is the relationship between left bundle branch block and progression to high-grade AV block? One of the questions we would like to answer. We don't know for sure based on some of these retrospective analyses, but limited data on the association of new onset of left bundle branch block with the risk of AV block. Clearly, there may have been more with some of the older valves, the core valves, as opposed to the sapien valve. And the newer valves, approximately, let's see, there's limited data. However, less is known about the newer generation valves. And even if you may have the same incidence of new left bundle branch block, it's not clear that necessarily the same relationship exists with respect to high-grade AV block. But what is known is that univariate analysis, having a new left bundle branch block is associated with an increased chance of getting a pacemaker implanted at some point, either early or late. And that's not necessarily a hard clinical endpoint because pacemaker may be implanted for prophylactic reasons, may be operator dependent. It's not just having a pacemaker in itself doesn't necessarily mean that the pacemaker is being utilized, as we alluded to earlier as well. So we'll shift a little bit and kind of talk a little bit about just in general pacemaker implantation in patients post-TAVR. And previous literature has shown a variety of factors influencing that, right? Pre-existing condition disease, new left bundle branch block or high-grade AV block in the post-procedural period. And TAVR in general compared to surgical aortic valves thought to have maybe a higher incidence of pacemaker implantation given that these patients have historically been had more comorbidities and have a different mechanism of valve deployment, and then different types of valves depending on whether they're self-expandable or balloon expandable. So this is a summary of pacemaker implantation after transcatheter aortic valve replacement. And as you see, there's a wide variation. But in general, if you compare the prior generation valves, the Medtronic core valve tended to have a higher pacemaker implantation rate post-procedure than the Sapien valve did, but anywhere from a little less than 5% to up to 35 to 40% in some case series. Looking at the newer generation valves like Sapien 3, Evolute, there still is a significant percentage of patients who undergo pacemaker implantation after the Tavor, anywhere, again, from a very low series to up to upwards of 30%. The Lotus valve here, upwards of 35%. So depending on the operators, depending on the center, depending on the valve, there is still a high rate of pacemaker implantation in these patients, even with newer generation valves, implicating that this is an issue that we're probably likely to see going forward as well. So what are some of the data with heart block with the later generation Tavor valves? This was a study published in JACC of about 158 patients with the Sapien 3 and Evolute. There were 9 and 14 who required inpatient pacemaker implant, presumably related to high-grade AV block. I want to point out a couple of interesting things about this study. 4 patients represented with late heart block following uncomplicated Tavor. And interestingly, all of these patients had unchanged periprocedural ECGs, meaning they were discharged with normal QRS duration. And the average hospital duration was 48 hours, and the mean time of readmission was 8 to 10 days when they presented with symptoms of heart block. And one actually had a syncope that resulted in intracranial hemorrhage. And you might ask, well, why would a narrow QRS, a patient with narrow QRS, potentially be at risk for developing heart block? There could be a number of different mechanisms. One is that it could be maybe a late progression from the valve implantation, but also it is possible to be fooled by the electrical changes on an EKG. You could have potentially concomitant delay in both the right and the left bundles and have what appears to be narrow QRS, but intrinsic conduction impairment in the His Purkinje system or damage to the His bundle itself, or what we call intraHisian disease. Recall that anatomical schematic that I showed you earlier. Depending on what level and what the anatomy of the conduction disease is in a given patient. So this kind of leads me to an interesting article that I just want to kind of point out, because this was an approach by another team, kind of a novel approach at the time, to do an electrical study, either pre and post Tavor implant, to assess that HV interval, to assess what the intrinsic conduction is like before and after Tavor. And they took baseline measurements, and they looked at these patients who had a pacemaker implant after the procedure and followed them for development of heart block. And this is an EP schematic of what we look for when we measure the His bundle. So we have a catheter across the His bundle coming up here, and we can tell based on the electrical conduction, the conduction time through the AV junction and then to the ventricle. So the PR interval is represented by this AH interval in the EP lab, and then the conduction from the AV nodes and exit from the ventricle is represented by the HP interval. And this represents essentially conduction delay or how normal the conduction is. Normal HP interval is about 35 to 55 milliseconds from this point in the conduction system out until the electrical signals exit in the Purkinje system. So if there is damage to the left bundle branch block or the right bundle branch block or the His bundle itself, we would expect to see prolongation of this HV interval. And this is something we can measure. Now, one potential caveat to this is that this may be a dynamic relationship. So in this study, they tested it before and then a given time point after Tavor, but this may be something that changes after Tavor, and that would be a potential criticism of doing this. But it is interesting, just wanted to report their results, that they had 75 patients and 62 with normal QRS durations pre-procedure, and 30 of these patients developed left bundle branch block after the Tavor implantation. And there were 7 recuperation of left bundle branch block, 6 with AV block at the time of hospitalization. And then after discharge, there were 2 patients that came back with AV block, with a new left bundle branch block at the time of the procedure. So out of the 30 patients, 8 had developed AV block implicating a pacemaker, and then 14 out of the 30 had persistent left bundle branch block. So a significant number of patients who developed heart block after developing a new left bundle branch block after this procedure, in this case series. And so I just want to point out a couple other. So if you have, with prior right bundle branch block, as we expect, if 5 of 6 patients with prior right bundle branch block developed AV block, all within 24 hours of TAVR, and all patients had pacemaker implantation and were dependent after 1 to 2 years of follow-up. 7 patients had pre-existing left bundle branch block. Only 1 of these patients received a prophylactic pacemaker and became pacer dependent. So what were the factors? They were able to assess what factors were associated with complete heart block. They found that presence of right bundle, new onset left bundle, and QRS duration were associated. But in multivariate analysis, the only thing that came out as being predictive of developing complete heart block was actually that change in that HV interval assessed on electrophysiology study. And if you took out the pre-assessment, if their QRS widened significantly, this was predictive as well. So kind of an interesting way to care for these patients perioperatively and determine whether or not a pacemaker may be indicated. So the take-away points from all of this discussion is that the optimal management of conduction issues, particularly new onset left bundle branch block after TAVR, remains a clinical conundrum. Results regarding the progression to high-grade AV block and pacemaker implantation are inconsistent. The timing of progression is inconsistent as well. And then, as you know, the TAVR population with this revolutionary technology is expanding, and newer valves still contribute to new left bundle branch block. And there is variable clinical practice across the country. So even in the same group, there are different clinical recommendations when that EP consult is placed. And so our goal in our section and in this institution is to try to protocolize and develop a systematic approach. So you know, and there's a standardization of care among the patients that have this issue. High-grade AV block can result in serious complications. And the left bundle branch block, particularly if greater than 160 milliseconds, is associated with higher mortality after TAVR. And current studies may be underestimating pacemaker utilization, as many patients with prior pacemaker implants are not included in these series. But what is ultimately true is that pacemaker implantation is not a hard clinical endpoint of conduction disease. It does not necessarily equal high-grade AV block. And so we really do need more clinical outcomes. So what we've done historically, and it kind of goes back to those 2 cases that you saw at the very beginning, where there were very serious clinical consequences, sequelae related to conduction disease, is that we have been taking an approach here in our institution to prophylactically implant pacemakers for new left bundle branch block, particularly if they're wide, in our case greater than 140 milliseconds, and if there are other electrical parameters that we see that are concerning, such as new left axis or associated AV delay, like first-degree AV block. And as a result, we've tried to do this uniformly, and it's helped because we've been able to go back now and assess what those implants have resulted in, how those patients have done over time. And that's what we're in the process of doing. Mike McGalley is one of our wonderful cardiology fellows who's really taken this project to the next level, putting all this data together. It started with a summer intern project with John Henstrom, Lucille Anzia, and Pamela Morley. So what are we looking at? We're looking at predictors of conduction disturbances and timing of the occurrences in these patients who have, and the difference in our population is that they had prophylactic pacemaker implantations for left bundle branch block almost across the board, given our attempt to systematically protocolize this. And we looked at predictors of pacemaker utilization, early and long-term, or lack of utilization. And then we want to look at other pacemaker data that may predict outcomes, such as the type of pacemaker utilized, the programming of that pacemaker. And remember, pacemakers do more than pace, they also detect arrhythmias. We wanted to see what types of arrhythmias were picked up in these patients as a potential mode of death or long-term outcomes. So again, we want to characterize the patient population that is at highest risk of requiring permanent pacing within 1 year after aortic valve replacement, TAVR, in the MHI TAVR database, recognize predictors of high pacemaker utilization. We alluded to this earlier, that it is very difficult to determine pacemaker dependency, particularly retrospectively, because the percentage of pacing may not always be 100%. And even if you have greater than 40% ventricular pacing, that may be clinically relevant, but does not always constitute dependency. think of a patient with atrial fibrillation, for example, with relatively slow ventricular rates. They may be paced more than 40% of the time, but if their rates are relatively well controlled and they're not too bradycardic, they may not be symptomatic necessarily without the pacemaker. One thing that we have noticed is that ventricular pacing percentage may also be sequelae of pacemaker programming. In our institution, we do a phenomenal job, our pacemaker nurses, to attempt to adjust the pacemaker programming depending on what they see to try to minimize right ventricular pacing, as we know the potential deleterious effects of that. There are patients in our series that were implanted at a different institution, in fact, who were implanted with devices that did not allow for reducing RV pacing, given that they may have thought that these conduction deficits, which occur at the time of implant, are always persistent, which we know not to be the case. So that's something that is worth making people aware of. And then there are patients, two patients in our registry, as you'll see, that had atrial fibrillation with slow ventricular rates that we kind of characterized based on our protocol as being dependent, but you could potentially consider that they're not classically dependent. So our patients underwent Tavor between 2012 and 2017. This was an Align IRB approved study. Patients underwent pacemaker implant within 1 month of the procedure and commonly prior to discharge. Patients must have had at least one pacemaker interrogation or clinical visit and follow-up to assess whether or not their device was utilized. So in our analysis, there were 720 Tavor patients, of which 172 underwent pacemaker implantation. The largest indication was advanced complete heart block or high-grade AV block procedurally. There were 36% of patients who underwent pacemaker implantation given the presence of a new left bundle branch block, and this was prophylactically given the concern for potential to high-grade AV block. We looked at these patients closely in follow-up, and we found that about 4 or 6.3% were partially dependent, and 2 of these patients were patients with AFib with slow ventricular rates who were pacing more than 40%, but not necessarily fully dependent. And then there were 2 that were essentially pacing all the time. And we'll go over some of these patients in a little bit more detail just to give you a sense of how difficult it is to make this determination. And you can see the length of follow-up. But so 3 patients of the 63 did not have adequate follow-up and were excluded. 6 patients were dependent on pacemaker at the median follow-up of 386 days. 2 patients we deemed to be completely independent and 4 partially dependent. And 5 patients had mention of intraoperative pauses or heart block with recovery to left bundle branch block. Again, signifying that the conduction issues may be plastic, especially after. So now this is not something that's repeatedly always mentioned necessarily in trial. It's very hard to extract from the note. But it was interesting that 5 patients had mention of significant intraoperative heart block, only to have left bundle branch block in follow-up, and who are not ultimately utilizing their pacemakers in any significant degree. So here, pacemaker dependency of left bundle branch block patients. I don't want you to memorize, actually I do want you to memorize this. No, I don't want you to memorize this slide. But I do want you to kind of get a sense of what factors Mike, along with our valve team and our imaging team, have been looking at in terms of trying to figure out what mechanical factors may be associated with left bundle branch block and pacer dependency. These are the 6 patients that we deem to be pacer dependent, either partially or completely dependent, and looking at Tavor valve, Tavor depth, the aorta, calcification of the aorta, the septum size, calcification in the non-coronary cusp, calcium of the basal septum. There are many factors, and this is in flux as to what potentially could be predictive. So far, because the numbers are relatively small, we haven't really found any mechanical predictors, but that is yet to be determined. I did want to show you a little bit of the number of valves, the types of valves. We have a very good cross-section of valves, both early generation and newer generation valves, core valve and sapien to start with, but also the Evolute, the St. Jude, one Lotus valve. So a number of valves that were incorporated in these patients who had pacemakers. And I just want to kind of, in a sense of time, just kind of move forward and kind of focus on a couple of takeaway points. So these were the 4 pacemaker partial or complete dependent patients if you exclude the patients who had AFib with low ventricular rates. And I want to show you this because any protocol that one develops should incorporate patients like these, essentially, so that they're protected once they get a pacemaker. So you have patient 1 who ended up having about 16% ventricular pacing in follow-up. he had this person, he or she had a first-degree AV block and left anterior fascicular block prior to TAVR, so pre-existing conduction disease, left spindle branch block with left axis post, and a QRS restoration of 148 milliseconds. Of note, this patient had an asystolic cardiac arrest 4 days after the TAVR, presumably related to complete heart block. And this was the valve that had been implanted, the 31 core valve. Patient 2 also deemed to be partially dependent, given that he wasn't pacing 100% of the time, but definitely a very clinically significant percentage of pacing with 40%, intact conduction at times, no pre-existing conduction disease, left axis and first degree post, and a very wide QRS, 178 milliseconds. This was the person who underwent SAPIEN 3 valve. And these two patients were essentially completely dependent. So there were no, in patient 3, there was no pre-existing conduction disease, QRS duration of 126 milliseconds, relatively narrow actually if you think about it, normal PR, and became pacer dependent at the first device check in checked and for some reason at 1 month, and was found to be completely dependent and pacing 100% of the time, had a core valve placed. In patient 4, pre-existing first degree AV block, QRS duration of 160 milliseconds with first degree AV block, intermittent heart block post pacemaker while in the hospital, and then ultimately found to be pacing all the time. So you see a wide variety of QRS complexes, a wide variety of types of valves, but clearly these are 4 patients who benefited from their pacemaker implant, and this is about 6% of the patients who had left bundle branch block after TAVR. We also found that a number of patients recovered their left bundle after TAVR. So there were 23.5% of patients who we saw at some point in clinical follow-up, either with EKG, who had an EKG and follow-up. And that time point is hard to assess retrospectively, but clearly there was a significant percentage of patients that did not have persistent left bundle branch block, which is supported in the literature as we talked about. On all of these patients who recovered their left bundle branch block were, of course, not pacemaker dependent. And there was a trend toward final valve depth being smaller in these patients with recovery, which is consistent with the literature as well. Our mortality aspect is somewhat primitive at this point because we have small numbers, so I don't want to focus too much of this, but I'd say that this is an earlier slide from Lucille after a summer research project in which she showed that there wasn't really much difference between the independent and dependent groups, and I'll tell you that there weren't very many complications associated with pacemaker implantation, none actually at our institution, which is quite remarkable given the number of pacemakers that were implanted. There was also an attempt to assess between the patients with recovery of left bundle and not, but this is also in flux in analysis. So what are the limitations? Well, this is a retrospective analysis with limited sample size. There's a variable length of follow-up, and it's very difficult to correlate ECG and pacemaker interrogations because they're done at variable time points in these patients' follow-up. And it's very difficult to retrospectively define clinically relevant pacing or pacer dependency, as we've talked about in some detail. Dr. Abdelhadi gave this idea, which we're looking into, as to how to, to say for sure if someone is pacing less than 1% or 1% or less than 5% is cutoff. But people could argue, if you're even pacing less than 1%, are you dependent at times, like that case 2 that I showed you? If the pacing is very limited, it's hard to make that argument, but at least you can propose that maybe the pacemaker is being utilized very minimally. The pacemaker choice and programming can predispose to higher burden of ventricular pacing, and it's difficult to ascertain whether biventricular pacemaker patients are dependent. So we had a number of patients who were on biventricular pacemakers were implanted because of reduced ejection fraction, and in those patients, unless you have very good long-term follow-up without the pacing, it's very hard just from the pacer interrogation to assess. So most likely, we identified the minimal number of patients who required clinically significant pacing, about 6%. So what we proposed, and this is a work in progress as well, and require some meetings between our sections and our group as a whole to try to identify the best practice going forward. But and this is incorporating some of the literature out there as well. But if you have a new left bundle branch block post-TAVR, QRS of 120 to 160 milliseconds, there are a variety of options that one has post-TAVR. I think we can all agree that we don't want to wait for symptoms. This is probably not a good approach given what we've seen associated with conduction disease in the post-TAVR period. However, in the narrower QRS patients, it would be an option to provide an external monitor of some sort, either an implantable cardiac monitor, or even do an EP study. One could argue that, especially for patients where we know their outcome is worse associated with their left bundle, and it could be related to progression to high-grade AV block, that if they have a greater QRS duration greater than 160 milliseconds or evidence of first-degree AV block or left axis deviation, that they should undergo prophylactic pacemaker implantation. So this is something that's a work in progress to assess, and it really depends on what you characterize as a threshold for pacemaker utilization on a population level, and this is where Steve and Craig may be able to help us as well. And what we'd ultimately like to do is develop a risk stratification scheme, maybe a score, to help, and this will require input from the procedure itself, from the electrical parameters, both pre and after the procedure, to assess for conduction disease and mechanical predictors and clinical predictors of heart block. And I just want to caveat that pacemaker utilization doesn't just mean pacing, it also means sensing. So we were able to look into the burden of atrial fibrillation in these patients, and Michael presented this abstract from our study at a Heart Rhythm Society conference last week in Boston, and it was identifying that many of these patients with pacemaker implant is kind of an incidental observation as part of their pacemaker utilization, that approximately 25% had atrial fibrillation diagnosed. And this is not post-operative atrial fibrillation, but rather subclinical. Actually, 15% was subclinical atrial fibrillation that was detected just based on their pacemaker interrogations in follow-up. And the incidence of stroke was higher in the new onset AFib flutter group compared to patients who remained in normal sinus rhythm. So it may provide a potential idea of monitoring these patients long-term regardless of their conduction issues, just given the risk of AFib and stroke. And Dr. Goessl feels that there may be other issues may be associated with that issue. So I want to thank Dr. Gornick and Dr. Almquist, particularly who kind of laid out the initial protocol in terms of clinically what we've followed for the last couple of years, and that led to an assessment of these patients with left bundle branch block, entire electrophysiology section, including all the advanced practice providers who are heavily involved in managing these patients. The structural heart team has been amazing. I really appreciate working with Dr. Goessl. Mike has been phenomenal in taking this work and presenting and working on these manuscripts, and Ross and Larissa from the foundation. And it really started with John Henstrom, who's actually a medical student. I still keep in touch with him. He's at the University of Iowa. And Lucia Lenzi and Pamela Morley last year, who worked on this project as well as part of the summer intern program. So I'll stop there, and I don't know if Mario wants to say just a few words, or I'll take questions at that point, and Mario can field questions as well. Sorry to take up most of the time, but thank you. Casey, yeah.
Did you guys look at success of the valve in these patients in terms of, is there less perivalvular leaking in the patients with conduction disease, with the notion that maybe that's what you have to deal with to get a very good outcome in terms of the mechanics of the valve?
Yeah, it's an interesting question, and I'll let Mario kind of chime in, but I mean, the architecture of the devices is developed to try to prevent KI, and as a result of that, sometimes the architecture tends to impinge more on the conduction apparatus, and so it is sometimes a conflicting issue with respect to that aspect, but I'll let Mario kind of chime in and see what you think.
I mean, the downside of everything is always that you want no perivalvular leak, ideally, or minimal to none. And so the companies have developed tremendously good valves. Unfortunately, they have shown in multiple studies that there's a high pacing rate. The issue with the pacing rate, I think, overall is that we don't know when we look at the TVT registry, why did people implant it, right? There's no reason. It's just a number, right? For us, for example, it's pretty high, 20%. But if you look at these data, and once we come together, we can probably reduce that number to almost 8, right? Because that is the true complete heart block number that we have. The rest is prophylactic implantation because we were scared, right? And then we also learned how to implant these valves. So some of them are safe, but if you implant them too low, then you have the pacemaker dependency, but still no perivalvular leak. Then the core valve, for example, is not on the market anymore. So 3 of our patients, you can basically exclude, luckily, because there is no core valve anymore. It's an Evolute, and with the Evolute, we don't see that, the 31. We don't see that issue anymore. So bottom line is if you look at all these dependent patients, and I always try to push Jay into the corner and say, okay, how many patients do you really think needed the pacemaker? And it's really tough because there is still 1 or 2 patients who would have died, right? And we don't want any death. So But bottom line, I think, is there's maybe one or two patients where we couldn't quite predict what happened, except for the immense, for example, there's one patient that had a complete heart block in the hospital, right? So it's still a predictor, right? You don't want to let that patient go. So there is, I think we're getting very close, and we have to all sit together to the point where we can say, okay, there's just a few patients who might need it. And then there's very interesting discussions with, the providers of valves and pacemakers. Maybe we should develop a Tavor pacemaker, right? So for those patients where we're really unsure, develop a program either with a micro device that is just, a little capsule in the right ventricle, or even a smaller device just to save the patient, these one or two patients that might have died. So I think this project is super interesting. I think nobody else has done it. We have to publish it, obviously, now quickly. These guys are twittering it everywhere. So,
just one other question. I'm going to hog it here. Does the EP service see all the patients pre-implant?
No, that's a big question. Jake, sorry.
How's the cost of the pacemakers covered? Is it rolled into the DRG so that Abbott eats the cost of this, or is it a separate thing that you can bill for?
At this point, we are billing for it as we would normally in terms of justifying the implants given the concern, and there's no consensus. And we're not the only group across the country that's doing this prophylactically. There are other groups. There's a wide variation but as you're right, that over time, as we get more evidence and there may be more restrictions, or this may be something that is reflectively looked at in terms of an issue, that could be an issue in terms of billing and reimbursement. Go ahead, Steve, sorry.
Great talk. To your point about wide variation, so our implantation rate based on TVT registry data is twice the national average, which suggests that we're very conservative, but maybe appropriately so, because the challenge is identifying those patients that you'd miss otherwise. The other challenge is finding centers who are doing things differently but are data-driven enough to know that it's actually the right thing to do, because other centers are probably just doing this blind. But I guess what comes to mind is, are there other high-volume centers? The Cleveland Clinic obviously has very high-quality data in a way that they'd probably be able to look at theirs and understand, and I'd be curious what their practice is.
Yeah.
Or other similar centers where they actually can use their data to understand whether or not they're targeting things appropriately.
Yeah, and as you know, we have a very good relationship with Cleveland Clinic. I spoke to my former mentors there over the weekend, actually, Dr. Lindsay, who's head of the program. They do not have a systematic way to deal with these patients. So it is kind of dependent on the person who's on the EP consult service at the time. They typically don't put prophylactic pacemakers in for left bundle branch block. They do put it in if they see some additional factors associated with high-grade AV block, such as first-degree AV block or left axis deviation. So that's our approach. And so I think in that sense we may be thinking a little bit ahead of them, but we have a ways to go in terms of identifying the true patient population at risk.
If you do what they do, and I just want to hear from all of you, now you saw the data, right? If you do what they do, and some people around us do the same, right? So they see a left bundle and say, oh, whatever. The data are not strong enough. We're not going to put a pacemaker in, see ya, right? If they don't follow their own patients year after year after year, with most of the big centers just don't do, right? How does Cleveland Clinic know where the patient that they just put a Tavor and went to to Florida and died there? They would never know that unless they look. Is that correct? I mean, they wouldn't know.
Well, that's a great point, Mario, and it's a testament to our patient follow-up and our patient clinic, and that is true. When I was in Cleveland, we rarely saw many of these patients in follow-up because they were from outside institution, outside location. But in our location, our pacemaker clinic has tremendous follow-up. 25,000 patient visits a year. I mean, it's impressive in Minnesota. So we can keep track of this data better than a lot of these larger institutions that are doing these procedures for their from outside hospitals, essentially, or other places.
Mike, Jay, that's really a nice body of work. Thanks for doing that. If we're at twice the national average, it should create a moment of introspection, which is what this is all about. a lot of the things that we think we know are unknown, so that there's no definitive guideline because there's no data surrounding that to make it better. Why not, and I think this is where you're headed anyway, so I'll just give you the opportunity to talk about it. Why not take the patients with left bundle branch block and start to randomize them based on the variables that you've figured out through analysis of your retrospectively of things that might be important, and then randomize an answer and try and answer it.
You hit it on the nail on the head, Mike. Yeah, that's exactly where we'd like to go.
Right?
That's exactly where we'd like to go. So we'd like to have a risk score. We'd like to have a randomization, and then really that would be the way to assess long term. And a LINC device may be reasonable for a lot of these patients, a monitoring tool like the LINC, not necessarily the LINC itself. But so that is essentially where we'd like to go. Yeah. And the other question comes up: is it the other extreme? Are patients with left bundle branch block better with a different type of device, maybe a biventricular pacing system as opposed to a single chamber device? So